Hi, I am Jessica Cash, and I'm here with Dr. Anna Herbst, my partner of Salt Health, and my partner in life and Salt Health, Jordan Cash. And I am so excited to be here today to talk to them because we want to talk about the state of healthcare. And there's a lot of buzz in the air today in the news and just in the community of the problems in healthcare and ways that it can be fixed. And I wanted to get your opinions about, just from your expertise, your years in the industry, in the healthcare industry, and what you've seen. So Americans are spending more on healthcare than ever before. And I think I've heard this statistic about that this is going to be the first generation where life expectancy is actually less than previous generations. We've slowly been building and it's going backwards, and chronic disease is on the rise, and we're spending more than ever. So why do you think the system is failing us, Dr. Herbst?
From my opinion and from my observations over the years, I would say we have a tendency from the provider side, we have a tendency to be disjointed. So there's not a lot of talk between a specialist and another specialist and the patient's primary care, insurance companies, medications that they're on. And so unfortunately, what that means is there's tests that are rerun, imaging that's redone, we're excessively working up the patient's problems as a first problem. And so that just means more money out of the pocket of the patient, more money to the system, burdening the system, more demand on labor and intensive hospitalizations and need for more doctors. And so when you pile all that together, it costs more money and it's creating a bigger debt, and it's not really getting to a cohesive problem solving. You're not getting a cohesive problem solved. So you're just spending more money, you're pedaling your wheels in the same spot, and unfortunately, that's one of the problems. The other one that I see is polypharmacy and lack of access, meaning that they can't get what they need, so they go to another one, then the whole process starts over again, and that just compounds and compounds and compounds. So to me, that's one of the biggest problems.
Yeah, it's funny. I love your answer. It's spot on. I actually was just looking at something I thought was pretty incredible as well. Is in a lot of things, technology has reduced the cost, making stuff more, excellent products, services available to more people. In the craziest way, technology has not really decreased the cost in healthcare. And so we have all of these great new, CT scans, MRIs, all this AI, all this exciting, great stuff. But as we introduce more technology into healthcare, somehow we have only seen the cost increase. What you also have seen is a huge increase in the burden and the burnout from the providers and the healthcare workers. So I think as you're talking about the life expectancy, the access, and then also the increased cost, perhaps the scariest thing is that, you have less and less people who are excited about entering medicine. And that's why you're seeing physician shortages. That's why you're seeing, retired healthcare workers at younger ages to go into other careers, is because they're stressed, they're burnt out, they're feeling that burden. And so you add on the stress of the patient associated with the rising cost and the decreased life expectancy and all of the rising, as you said, multiple comorbidities and lots of ways for people to be more and more sick. It's kind of a perfect storm. There's a lot going on, and people are looking for answers.
Yeah. It's a total burden, a burden to the system, a burden to the patient, a burden to the healthcare workers. And that, to me, is probably more costly than a monetary value. Like, we can't put money on that, in my opinion.
Yeah, there's emotional burden. That really, I think, gets discounted, that people don't think about or talk about. And, again, you think, oh, it's financial, there's stress associated with being busy and this, but man, when you can't find answers and you're not feeling better and you feel like you're a hamster in a wheel, or that you're getting tossed from, specialist to specialist, or that your primary care is, only spending 6 or 7 minutes with you and they don't really get to the depth or to the root cause, it really takes an emotional toll on people where they feel helpless.
I don't think the general public doesn't understand how insurance billing drives costs. So can you help enlighten us a little bit about, and by driving costs, I mean from everything from how long a physician can spend with you, what kind of care is even possible? And so how is the Salt Health method and what we've created different, and how does it address that in particular?
You want to start with it?
Sure. I want your insight though.
Okay.
We did a podcast together, Jessica, you and I, not too long ago. And the structure in the system itself, I think, is something I won't go into great detail, but there's a burden that the provider feels where they have to, see 30, 35 patients a day in a primary care setting in order to, be able to bill enough to meet the requirements for, their productivity or for their health system or for whatever else it may be. And that results in that, as I said, 6 to 7 minutes per physician visit. You're then trying to code as high as possible for that visit to try to get that healthcare, insurance billing up as high as possible. Of course, you want it to be accurate, but at the same time, there's some burden in that as well. So the administrative side, the amount of time you spend in documenting, in providing additional support that justifies what billing code or level you're trying to achieve. All of those things drive on the insurance side, what the reimbursement's going to be. And so as you then go to the next level, it's okay, you want to be referred for an MRI or for to see a cardiologist or to have a procedure with a GI doc. Then a lot of times there'll be prior authorizations or additional documentation or things that are needed on the primary care side again. Before they would even approve, paying for a study. They might determine that that's exploratory and that we don't have enough, data or history to show that that's really necessary. So you've got somebody in, Iowa sitting at a computer determining whether, the patient actually should qualify for a test or to, have a procedure. Meanwhile, I've got Dr. Herbst sitting here who spent time with the patient and actually determined that this test would be extremely beneficial, but insurance is actually dictating and determining whether that care is going to be approved or not. And the patient, who is so accustomed to using insurance and feeling that's their only method of receiving care, is not going to go and say, okay, well, I'll go see if I can get a cash-based price to go do that test. If my insurance is denying it, I guess I can't do it. And so that's where that dictating care comes in. And again, it could be for a sleep study, it could be an MRI, it could be for a specialty referral, it could be for a procedure. And so that burden goes back to the clinic and it goes back to the provider, it goes back to the physician. And it's a constant game being played as will this be approved by insurance? Do I have enough documentation? Have I justified it enough? And again, it leads to that burden and burnout.
Mm-hmm. And dissatisfaction or confusion from a patient standpoint. I give an example. I can only say from clinical experience, and I do want to preface really fast. Insurance isn't bad. And at SALT, we have decided that it's really important to have insurance, especially catastrophic insurance. But there's other ways of going about your healthcare solutions and getting the care you need that's sort of like a nice complementary blend of worlds, and that I don't think many people are familiar with. So hopefully we'll get to that, but that's what we're opening your eyes. So I just want to say we're not anti-insurance by any means. But my experience is, for example, I needed an EKG for mid-40 male that had family history of heart disease, and he's a little worried. He's getting ready to start a training routine with a trainer, and they're going to run on the treadmill, and they're going to do some exercise. And he said, I'd really like to make sure my heart's okay. So I put in for a stress test, a treadmill stress test. It got denied because it wasn't medically necessary. I got on the phone to appeal it, which of course that takes 30 minutes or so. And as I'm talking to the physician, he apologized and said, I'm so sorry. It's not medically necessary. You've told me he doesn't have chest pain. He's not currently having any palpitations or arrhythmias or any sort of, heart disease. So it's going to be denied. And ironically, I said, so if I put him on the treadmill and he has a heart attack or he has chest pain, then I can get this approved. And he said, well, unfortunately, yeah, that does sound like it's how it's going to work. So to me, it's those sort of stories over and over that really burden us as providers, because we're trying to do the best for the patient. And so you do that day in, day out, deny appeal, deny appeal, deny appeal. And it's a game. And the patient's on the other side saying, well, how come you didn't get that approved? That doesn't make any sense. So anyway, I know it's not any one person's fault and the person on the other side is doing their job, but it's frustrating. It's tiring.
It's part of what's driving costs because people
absolutely
reimbursed for their time.
Yep.
And their expertise and knowing.
Or they'll just drop it and not even appeal for the patient. So then the patient's like, well, now what do I do? Go on to the next.
I love that.
I think that's part of what our heart was in starting Salt Health is it's all about that primary care. It's all about that foundation, and that we don't believe necessarily needs to be covered by insurance because you're doing preventative, and hopefully then it saves the specialties for later. Okay, let's do everything we can to keep you strong and healthy, and it keeps costs down. I know that at least that was, our business model and our idea and what we're seeing with our patients.
For sure.
Yeah, I think one of the problems again, and I'm with Dr. Herbst. I mean, we have insurance for our employees. We want everyone to be insured. You need some level of coverage. I think the hard part is a lot of people have insurance, but they still see it as a disincentive to actually go and receive care, because every time they go, it's still going to be out of pocket until they've met that deductible. Or if they met the deductible, there may still be co-insurance, and there may still be out-of-pocket maximums. And so they may think, well, that example you gave, I love. Thank you for going down that road. A 40-year-old male, he might say, well, I don't even really need to go to the doctor because I'm going to go to the doctor. If I go to the doctor 3 times a year, it's all going to be out of pocket for the whole year. I'm going to end up spending another $1,500 to have 3 7-minute visits with my doctor. And here I am paying $800 a month premiums. And so he doesn't feel that he's getting any value for his money by having insurance, and then it's just a catastrophic or an emergency plan, and he's disincentivized by going and actually actively trying to get care. And so I think, as we were talking about the model of self-health, the goal was, well, how do you get proactive engagement, and how do you know going in what's your monthly cost going to be, what's your experience going to be, how can we be transparent in all of the costs associated with your care. If you need additional labs, if you need additional testing being run, we can show you what the price of that's going to be. You can run it through your insurance if you have insurance, if it's approved, if you have that side. But it's about having an active relationship that is engaging and prioritizing a preventative health.
So we've all heard about the specialty shuffle, and it's basically disjointed healthcare. And so, Dr. Herbst, talk a little bit about your passion for true primary care and functional primary care, as you call it, and how that helps provide a more cohesive experience.
Perfect. So the primary care part, I like to think of it as the good old-fashioned doctor, the rural doc.
Absolutely.
Had practiced in rural medicine, and you don't have all of the specialists readily available to you, so you have to learn how to do some of these things on your own. We are trained to do them, but it becomes easy, it becomes expected to just refer out. And so then you're basically become the master of the orchestra. You send to one, you send to another, and then hopefully they come back to you and you can make sure that they're not on 3 of the same medications from 3 different doctors, that they're actually getting what their problem was worked up. And so that you become, a master conductor. You're just making sure everything is okay in the pot. However, if you dial it back and you become a real good, all-encompassing primary care, in my opinion, we're able to minimize the amount of times we refer out to specialists. It's not that we don't need them. By gosh, we need
Absolutely.
all of them. And we need that next step workup. But there's a lot of stuff that we're taught to do that we can do that we don't do. And so the patient can get a really decent workup and probably not need to go to the next step for a while because we can do it there in-house. And then if we need next step help, we will go there. Or sometimes we need the big help for the specialist and then we bring them back in and manage it. Therefore, they don't have to see the specialist multiple times or hit another specialist in that avenue. So I think it's kind of what I think of as the good old-fashioned doc, that used to do house calls and cut your mole off and also treats your strep throat and maybe does your pap smear.
We do your birth to death.
Well exams. And yeah, absolutely. And do all of them. And you get to know the family. You get to know the patient inside and out. You get to know their stressors. You get to know their things that make them happy and joyful. And by doing that and checking on them frequently and having these touch points, you're being preventive. You're catching things before they become a big, huge problem. And so we can, I think, manage, primary care in that way at SALT. That was our dream. And then if on the other side, we also bring in that functional medicine lens where we're looking at root cause. So you have hypertension or high blood pressure, you have cholesterol issues. What can we do from a team standpoint, dietary, lifestyle? Primary guideline recommendations is always lifestyle first for most all diseases, chronic diseases. We target those. We help you correct them. We hold you accountable. We touch point regularly. We get to spend time finding out that your stress has really been high, so therefore you stopped eating healthy. You're now eating at McDonald's every day, or you're running, fast food restaurants in and out all day long. You've increased your alcohol intake because your stress is high. We can catch that early. We don't wait 6 months to see you, twice a year when it's all kind of gone backwards. And now we need several medications and we need to see the specialist. And so I think there's many parts that root cause comes into play with the functional and lifestyle combination with primary care.
I want to note a couple of things because I just heard a stat recently, and you mentioned hypertension, that 30% of cardiologist visits are managing hypertension, and the bulk of that could be actually managed by primary care.
Yeah.
And again,
they would prefer we do it.
Well, that was what I was going to say, is coming from the hospital setting. So again, I've been in the health system hospital setting world for 15 plus years. I can promise you without a doubt, the cardiologists don't really want 30% of their patient load to be hypertension patients.
Already short on cardiologists.
Yeah.
Cardiologist time.
And again, that's that system as we kind of go back. Well, the problem is there's primary care shortage. And so if you have access problems at the most basic primary care, every cardiologist that I've ever talked to would say they want more primary care in their area so that they have more referral sources, but they're actually managing the things that could be managed by the primary care and not have to come, sent to the cardiologist. The same as in, say, general surgery. I'll give another example is the general surgeon, they like to operate. They don't really. That's what they're good at. That's what we should use them for. They don't really want to or need to be talking to the patients about diet. That needs to be occurring before they get to the general surgeon. But a lot of times general surgeons will find themselves saying, oh my gosh, they've had no primary care. They've not had a thorough workup to even look at a diet, lifestyle, nutrition, plan. And so here they are in the general surgeon's office, and yeah, they could operate them, but they might actually try, and then they have less time for their surgical patients. And so it really is a shift in the system. And I love the old rural hometown family doc that you referred to, because 20 years ago, most of the doctors would be inpatient, be outpatient. They would see the whole family. And as we've made a shift, we now have hospitalists. We now have outpatient only, or mostly outpatient only for family medicine, and they're referring to specialists more often and quicker. Again, a recent statistic that they're referring out at twice the rate that they were 20 years ago to specialists. And it's not because they can't manage them. It's because they don't have time.
Yeah. I was going to say it's time.
Yeah.
If you don't have more than 7 minutes or 10 minutes with the patient, it's very difficult to manage 3 illnesses that are pressing. So instead, what do? You do the best you can. You reach for a lifeline. You phone a friend. Yep. You refer out and you say, this person's got this going on, this going on, this going on. I don't have time to address them. They failed 2 medicines already. I don't know what the next best one would be. I could take time to look it up. I could look at all their other stuff, but I'm just going to send it to somebody else. And unfortunately, that's just what we've started to do, and we do more and more and more of. And people are getting more and more sick. So that's the other part of it. It's a very complex chronic illness, comorbid, illness sort of presentation. And so you're not just managing one thing, you're managing multiple things. And to go back to our model, it starts with changing lifestyle. People that we could probably minimize meds or get off medication if we just had the accountability and the education and the time to educate them and the time to sit with them and find out what their hurdles are, why they can't achieve that goal, why they can't change their diet, why they can't stop drinking, why they can't stop smoking, and help them, give them, provide it. But you have to have time to do that. You can't do that in 6 minutes. It's impossible.
You can't even list all the comorbidities in 6 minutes.
Yeah, I think I talk more than 6 minutes there, I think.
Yeah.
So, I mean, you bring in such a good point about how not only are primary care doctors stretched, they're seeing tons of patients on tons of times. They have this huge administrative burden, but they also don't have the resources. So, I've heard you talk a lot about how nutrition is not really highlighted in med school. And so talk a little bit about that and how we do things differently and how, our kind of model can help with that.
I think it's starting to shift, and we're realizing that need for lifestyle modification, diet is really important. But as y'all know, and unfortunately in medical practice, applicable practice of medicine, it takes almost 20 years for a need or a change or a new bit of information to actually become applicable or applied in medicine. So it's a delayed, we needed it and we should be doing it and it's coming, but it takes some time. So now we're at the point where everybody's saying, we need to do this, but we now have to train our students. We have to train our doctors. I took an elective, class on nutrition, but it really isn't a standard class that's required in medical school. So we're taught that it's important, but we're not really taught it. We don't really know it. So then we lean on our dietetics friends and so forth for that information. But it's really
most primary care offices don't have access to those resources.
No.
Refer it to a hospital, maybe.
Exactly.
Where you might be able to find a dietitian.
Exactly. I mean, I had a background of naturopathic medicine and nutrition, and then I took some electives through med school, but I still am not an expert in that field. So therefore, it was a requirement for SALT to have an expert in that field on the team, because we need someone that can actually teach this and help our patients change, what they're doing.
I feel like I talk about that example more often than not. It's not, again, you said it perfectly. It's not that even physicians, even if they weren't trained in it, that they don't want to, refer to a dietitian or have discussion about lifestyle and diet. The time is an issue. And then the second piece is, not only do they not have a dietitian in the clinic, they may not even know a dietitian that they can refer someone to. And so that's what I love about SALT, and I use as an example all the time, is I have physically seen Dr. Herbst leave a patient room and say, I'm going to go get our dietitian, and bring them back and ensure that that conversation continues. They have a follow-up appointment dedicated with the dietitian. And so there's a trust factor that our dietitian, Tim, is a part of our SALT Health team, is a part of our daily, huddles, is in our collaboration space, officing with Dr. Herbst and Jacob and our health coach, Whitney, all together. And so that constant flow of communication and that collaboration from a team approach to include lifestyle and diet as a true focus and to be intentional in it, I think is one of the greatest benefits of the SALT Health model. Is we don't just talk about the resources. Same thing with personal training or massage therapy. We can say, there is actually a medical side to this that we can, collaborate with the team, and they know that they have a resource that's available that's aligned with our care.
Yep. So, Dr. Herbst, most Americans wait until you're sick.
Sure.
I mean, I grew up in a family where you're pretty much probably should be in the hospital by the time we would seek medical care. Hopefully we're making changes.
Yeah.
So tell us what your vision of functional primary care, well care looks like.
Yeah. So we're trying to shift from that pill for an ill sort of acute care model into more of a root cause. Why is the person presenting the way they're presenting? What can we do to help change that? How can we minimize need for medication? How can we prevent further progression of the disease? And so the acute care model would be, I have a symptom, here's a pill, here's a prescription, here's a surgery, here's a something, a lifestyle change, whatever. The root of that problem is asking the question, why? Why does the person have what they have that they're presenting with in front of you? What are we going to do to change that? And how can we stop it? How can we take away what's keeping it going? So I guess hopefully that answers your question. The acute care versus this new root cause approach.
So give us an example of like hypertension. It's a really common diagnosis. So, a traditional model, you go see your physician once a year to get a prescription. Tell us how it would look different in both settings.
Okay, so blood pressure, first of all, it's individual. That goes to the dietitian discussion as well. It's interesting, our dietitian actually will tailor his dietetic approach to each person's disease or preventive cause. Like if they're looking to prevent high blood pressure, as you were just speaking of, or if they're trying to reverse, high cholesterol, or if they're trying to prevent diabetes. It's actually a different dietary approach for each of those individuals, as it would be for anybody that comes in with blood pressure. Not everybody's high blood pressure or hypertension, as you just said, not everybody's high blood pressure is caused by the same thing. So is it your kidneys? Is it diet? Is it too much salt? Is it the obesity factor? Is it inflammation? Is it a combination of those sorts of things? So is it a deficiency in magnesium, for example? So there's a lot of reasons or things that can cause high blood pressure. So the question is getting to know the person's history. There'll be clues along the way, something that's happened. I got hit in the back. I was in a car accident, had a kidney injury, blah, blah, blah. So might be clues or hints. I eat a lot of fast food. I'm always on the road. I drive truck, blah, blah, blah. Oh, that's a lot of sodium coming in. So there's different clues that we can then start to take away or remove out of the equation and see what's left over. If you still have high blood pressure, it is absolutely imperative you treat it with the medication or treat it so that it's in a normal range so you don't get further progression of other organ disease, eyes, kidneys, etc. So it's not that we're against medicine. It's just that you have to figure out the root cause for the person and whatever it is they're presenting as what's driving theirs, what's making it not normal. And then you target those things the best you can. You teach the patient how to be empowered to target those things. And then what's left over is what you treat. So medicine, no medicine, just depends on the patient. That's the way I would approach high blood pressure, or what way we approach, I should say, at SALT.
And it is. And oftentimes we're able to help reduce medication, help people get medication, help people lose weight, because we're getting healthy on the inside, which is exciting. And it's fun to do the preventive side because those of us that have had high blood pressure in our families for generations, and it's just, expected that you're going to have, if I can be the last person that has to deal with that, if I can make changes for future generations.
Absolutely.
And I'm smiling real big because I was actually talking with one of our members today, referring to her teenage child, and how his life has been transformed as a member at SALT. And it was so cool. Like I loved hearing from her, but she was, talking about it's more than just weight loss, but energy, activity, sleep. If you look at the trajectory of the average, and I hate to say that, but the average, but nearly, half of kids are reaching obesity levels of or at least overweight. And so as you look at that, there's so many things that are in their path or projection or trajectory over the next 30 years. If we can intervene at a critical point in time in their life, we can transform what their life will look like, how they'll be able to have a family of their own, how they'll be able to have a job, how they'll be able to be creative, how they'll be able to, help solve major world problems. I mean, we have an entire generation that is not as active, that is very focused on, looking at screens rather than getting out and being active. And knowing that about 20% of our membership at SALT is under 18, I love it because we're investing in that next generation and partnering with people. And when I hear stories like that, it just makes me really, really excited about being a part of SALT Health.
So, I want to go two directions here. Doctors, I want you to give me your one person Jacob is one person. We only have one team. There's only so many touch points that we can do, in a day. And so how do you see this revolution or changing of healthcare? How do you see that going, and how do you see the way forward? What are some of the things that you've seen successful for being able to reach more people?
Education. So talks like this are great. I think this is what you're asking me, right? I keep saying we need to be a voice for rural America. I watched the progression of medicine and research, and unfortunately in the United States, it always hits the East and West Coast first. They get all the cool stuff first, even fashion, right? And then it slowly trickles into the Midwest and right down the center, and that's where we are. And we, as Midwestern/Central United States people, we need and deserve good healthcare. We don't need to have to be able to fly to UCLA or to Mayo or to Cleveland Clinic or to California somewhere to get good healthcare. We should have it here. And so I think that, teaching and educating, bringing in med students, bringing in residents, showing that there's a different way to practice. There's an exciting way to practice. There's a passionate way to practice where people get well. They love coming to see you. You love to send them out knowing they're going to be successful. They're going to be as healthy as they can. I think that teaching and education is probably our number one. The other is supporting other physicians to implement this type of practice, to start this practice and not be afraid to step out on their own. We're not really taught a lot of business in residency and med school. Some have had it in their past, but not many. And so, as a team, as the pioneers of this new medical model that we've made successful, I hope that you, I, and Jordan can be leaders and educators to help other providers grow and do something like this in hopefully all across the United States, but really in that central United States first.
I think there's a couple things I would add, and one is the misalignment. You mentioned earlier kind of the structure of the traditional system as well as the payers. The misalignment is a lower value reimbursement and lower prioritization of healthcare dollars on the front end, and so on the primary care, on the health and wellness, on the prevention. The overwhelming majority of cost in the U.S. healthcare system is chronic conditions. And so as long as that misalignment is there, there's going to be a challenge. So for instance, I would say every health system in the country would go hire 50 dietitians if the reimbursement for those dietitian services was really good. But unfortunately,
short term, it's not.
Right now, it's not. And so again, the structure and the model is the higher paying services are traditionally on that back end and on the more chronic care conditions. So when somebody, and I don't mean to take this down the wrong road, but when somebody has cancer or serious heart disease, the reimbursement is much higher for those things. Well, our goal is, if they never get those, everyone wins. Their life is better, their family gets to enjoy them longer, all those wonderful things. But when that misalignment is there, it's going to create a little bit of a challenge. And so one of the things that I've heard you talk about a lot, and I love it, I think it's something that there needs to be more discussion and education around, is everything in our life is driven by the consumer. And is driven by the consumer's desires, whether it be in service, whether it be in excellence, whether it be in quality, and what they send their money to. And so when people prioritize their own funds to a model like Salt Health, where they're prioritizing their health, on the back end, they're going to save potentially millions, tens of thousands, hundreds of thousands, potentially millions over the life of their life, and the funds that are associated with healthcare costs. But it's tough to again see that up front. But if more and more people do that and more practices step out to focus on really diving into that prevention, wellness, and they find a way that, they can do so and be successful as a business also, you're going to have more and more people do that, and more of the healthcare dollars shift that direction, and you'll see some of that meaningful change. So that's not easy, that's not quick, but I do think that the structure alignment and the undercompensation for things like dietitian services or for family medicine or primary care on the front end definitely impact, why the system is not escalating or accelerating faster in this space.
We talk a lot about that there are other parts of our lives where, sacrifice up front, we know that, okay, well, it will help me prevention for the future, right? So, even things like going to college when you're young, that sacrifice of money and time and energy and effort is worth it for the future. And you have that mindset. But we haven't had that mindset with healthcare in America. There's not been a lot of, hey, if I do these things up front,
invest up front,
it's worth it down the long road. And so that's part of what our mission has been, is this getting excited about, there's this opportunity here. We're not destined to die in a sick and, and stressed and, depressed state. It's just not how it has to be. And that gets me excited. It gets me excited for my kids, because I want to do everything I can to invest for not only myself, but future generations. And so empowering people to not just, this is the way life goes, that I can take in control of my healthcare. I can be very personalized about how I eat and what supplements I take and what medications I take and, my sleep, everything. We're all on this journey and on this path, and it can start small, right? You're the best at helping motivate, because I've talked about it before on the podcast. I'm very all or nothing. and Baby steps is where you actually see the change.
Yeah, absolutely. They talk about, 10% change can lead to, and on average, a 10% improvement in quality of life. 10 years less, of misery, so to speak. So that's pretty neat. One of the outcomes studies I was participated in getting started when I was at Cleveland Clinic was, how much money are we going to save the patient out of pocket, and how much money can a root cause approach save the insurance companies, right? And it actually finally got published a couple of years ago, I think, when they finally finished and got all their data. And it was an overwhelming savings for both sides. So this approach is not a fast, I can see it right now, I can feel it, give me the drug, I can feel that, oh yay. It takes change, it takes time. But in the long run, that 14-year-old now will no longer have a higher risk for diabetes. He's no longer a higher risk for high blood pressure before he's 35. He's going to have quality of life and be able to run and play with his kids, So I think the investment up front seems sometimes a little heavier, but honestly, in the long run, you're less medications, you have less specialist office visits you're paying. You don't have to worry about a nursing home before the age of, 85, and you'll have good quality of life. And anyway, so I think that people need to shift their thinking to look at, more of a preventive model.
And I love it. It is true. There's even like very simple examples, like you can, your hot water tank goes out at your house. You can buy a $2,000 one or a $4,000 one. Well, the $4,000 one might be more reliable, and it might have energy savings that you then get every single month. Well, people make those choices all day long, like it's no big deal. But again, they don't think about it from the standpoint of healthcare, where it's like, well, if you do X, Y, Z, in the long run, you're going to be more reliable yourself. You're going to save money over time, and it just takes
You're not going to miss work.
You're not going to miss work.
You're not going to miss time with your kids.
Absolutely. And then I want to just note, because the majority of our podcast, without a doubt, are to educate, customers, to educate families, people who are interested in just learning more about what Salt Health is, and then also how they can get healthier in their lives. But Dr. Herbst did mention, and I think it's worth noting, that for providers who are feeling that burden, feeling that stress, feeling overwhelmed, feeling like they can't get ahead or that they can't practice the way they really want to practice.
Not getting people better, it hurts.
Right.
I go to work anymore.
We want to encourage those providers. We want to be on the sidelines with them. We want to help support them in ways. And fortunately, now that we've been for 5.5 years serving Northwest Arkansas, we do have the ability to partner with, other physicians or other practices, to help through some sort of affiliation or support that might help them. So if anyone's interested in that, I just really want to encourage providers. You don't have to be on your own completely, and you also don't have to be scared and think that you're, not capable or not able to do that. Start the discussions. You know what I mean? Just reach out. Let's see if we can talk a little bit more about what we've learned, what we think has worked well for us.
What's not worked?
Maybe we can save a year or two off of somebody's trying to do that because of the lessons we learned. Because I promise you, we didn't do everything right. But I do think that over time you learn and you improve, and we just want to get better every single day.
Yeah, for sure.
So Dr. Herbst, if there's somebody that's interested in healthcare, they're still a student, whether they're in med school or they're in nursing school, or, what would you say to them? If you could go, I know you kind of had a non-traditional journey, starting as a naturopath and getting well yourself.
Yeah.
But, as someone who is just passionate about helping people, and they're going, to med school, or they're going to some kind of healthcare education, what would you say to them?
Stay true to your heart. Don't follow the dollars. Follow your passion. Get your education and get your hands on every little bit of education you can. So take up the electives, do all of the extra things, and then really just follow your passion and follow where it takes you, and be a really great doctor. Be have good bedside manner. Listen to your patients. And I know that everybody knows that lifestyle stuff is important, but I can't say it enough that listen to that, know it, believe it, and practice it, and put it into practice. I think that's everything else will fall into place. Be fine.
I love that she just shared her heart with that, because that's also who she is. And I know, she's mentoring people all the time who are coming into the clinic. We even have a couple of team members who aspire to go to medical school. So I know that you're pouring your heart and sharing amazing practices and ideas with them on a daily basis. And I think the energy and excitement around getting America healthy, right? Let's tackle this. We can do this. Hopefully will inspire young people more and more to want to be a part of it. And again, if we can be a light in any way to say, hey, if you didn't know you can practice this way, but you can, man, that would be awesome. We would love to inspire and to partner with other physicians, whether they're currently in practice, whether they're currently in medical school or residency, or whether they're going to be entering. We'd love to just connect and find ways to help encourage you along the way.
Well, I appreciate you both being with me here today. I hope that we brought the listener some positivity and some light, because there's a lot swirling and it seems like a lot is negative, but there's a lot of really good things happening. And there's a lot of individuals out there doing really good things. And I think us uniting and encouraging each other and promoting wellness and health, and just continuing the education and the patient journey is nothing but good. And it can only lead to good things. So thank you both for being here today, and we'll see you next time.
Awesome. Thanks.